5 seconds, sir. Good to go.
Yes, okay. Hello everyone. This is the INI SS April 2024 Neurosurgery recall session. So in this session, we will discuss on the questions that we have collected from our students who have completed the INI SS Neurosurgery exam in the recent April 24. So without much delay, I'll go into the questions. Following an RTA, a 20-year-old male presented to the ER with a low GCS. On examination, he is opening eyes to pain, localizing pain with a right hand, utters inappropriate words on question. His pupils are unequal with no response to light on the right eye. What is his GCS P score? Option A 9, option B 10, option C 11, option D 12. The answer here is option A 9. So I'll explain this. So his GCS is E2, V3 and M5. So he's opening eyes to pain, which is E2, localizing pain, which is M5, and utters inappropriate words. So that is going to be V3. Now, what is this GCS P score? GCS P score is nothing but GCS minus non-reacting pupil. So whatever GCS you get, you subtract it from the non-reacting pupil. If there is one non-reacting pupil, then it is -1. If there is two non-reacting pupils, if both pupils are non-reacting, then it is -2. And if the pupils are both equal and reacting to light, then you give a score of 0. So GCS P score will be 10 minus 1, which is the non-reacting pupil. Hence the answer is option A 9. 5-year survival rate for operated meningioma, Simpson grade 0. So the 5-year survival rate for any meningioma is very good. And especially when you are able to achieve a Simpson grade 0, then it is more than 40%. So since the best answer here is 40%, we have went with that. The overall tumor recurrence rate for Simpson grade 1 resection would be 5%, 2 would be 22%, 3 would be 31%, and 4 would be 35%. So it has a very, very, very less recurrence rate. So a very good survival rate. The answer would be the largest possible number that we get. Okay. A 40-year-old male presents with water-like discharge from the nose following an RTA. His GCS is 15/15. CT brain is showing anterior skull base fracture with no evidence of any hematoma or depressed fracture. Clinically, a diagnosis of CSF rhinorrhea is made. So what is the next step in treatment? So here you have a 15/15 GCS with a CSF rhinorrhea. What is the next step in management? Antibiotics. Option B, operate. Option C, observe for 5 to 7 days. Or is it option D, an endoscopic emergency repair? The answer is you have to observe him for a small period, because most of the leaks, they tend to be self-limiting and they tend to heal on its own. So what are all the indications for early surgery? Indications for early surgery are penetrating injury, intracranial hematoma, meningitis, large pneumocephalus, herniation of brain tissue from nose and ear, and a low probability of natural dural repair. So all these are early indications for early surgery. So what are the indications for late surgery? Persistent CSF leakage after 10 days of conservative management, recurrence of delayed CSF leakage after 10 days of conservative management, recurrent pneumocephalus even after 10 days of conservative management, or the presence of meningitis and an abscess formation. So all these are indications for a late surgery. Question number 4. Who is considered as the father of microneurosurgery? The father of microneurosurgery is going to be Harvey Cushing. So he is considered as the father of microneurosurgery. Surgical management of Lennox-Gastaut syndrome. The surgical management of Lennox-Gastaut syndrome, is it option A, corpus callosotomy, option B, medial temporal lobectomy, option C, selective amygdalohypocapectomy, or is it option D, none of the above? So the answer for Lennox-Gastaut syndrome, surgical management would be corpus callosotomy. So this Lennox-Gastaut syndrome can be caused by a variety of conditions like brain malformations, tuberous sclerosis, perinatal asphyxia, following severe head injury, CNS infections, or certain inherited genetic and metabolic conditions. So generally, valproate is considered as the first line of therapy for these patients. Other anticonvulsant medicines include clobazam, felbamate, lamotrigine, rufinamide, topiramate, and cannabidiol. So definitive other treatment options when it comes to surgical management, it could be a vagus nerve stimulation or it could be the epilepsy surgery. If it is going to be epilepsy surgery, then typically a corpus callosotomy, which means severing the band of nerve fibers that connect the two halves of the brain to prevent the seizure from spreading. So that would be the surgical procedure that is being performed for these patients with Lennox-Gastaut syndrome. A 50-year-old female presented with complaints of severe pain on the right side of face for the past 3 years. So immediately you turn your attention towards trigeminal neuralgia. On tablet carbamazepine 3 months, she has been experiencing frequent episodes of pain which are not responding to the medications. So how do you manage this patient? See, she has already been on 4 months of tablet carbamazepine. So what are all the other options that you can give and what would be the best operation for a 50-year-old female? Option A, microvascular decompression. Option B, stereotactic surgery, that is stereotactic radiosurgery. Or is it C, increasing the dosage of medication? Or is it option D, glycerol injection? So she's a 50-year-old female, meaning she's in a productive life, both socially and economically. And the one procedure that can give her a maximal pain relief is going to be the microvascular decompression. So that would be the best treatment option for this patient. The most commonly performed surgical procedure is the microvascular decompression, where the vascular loop overlaying the trigeminal nerve is placed away from the root entry zone. Other surgical options include balloon decompression of the nerve root, radiofrequency thermocoagulation, glycerol rhizolysis, and stereotactic radiosurgery. So all these are the other options that are being performed. So the best answer would be the MVD. A 56-year-old male presents with complaints of sudden onset severe headache, is conscious, oriented, and obeying commands. And the image is missing here. It was actually a SH from the intrahemispheric fissure. So when you have an image with like this with the intrahemispheric fissure, then you can see the hemorrhage here. You can see the hemorrhage here. That is in the middle, right in the middle, just above the third ventricle. You can identify the hemorrhage. So this is the characteristic source of bleed from which of the following aneurysms? Is it A common aneurysm? Is it MCA? Is it PCA? Or is it BISLAR? The best answer would be the A common aneurysm because that is where exactly the anticommunicating artery is going to lie. So the answer is A common aneurysm. Question number 8 was about a 17-year-old boy who presents with complaints of neck pain and weakness in both hands. There's no evidence of wasting in both hands. MRI images as given below. What is not true regarding the possible diagnosis? So what you can see here is the cervical spine is unduly flexed. So there is loss of lordosis. There is significant loss of cervical lordosis that you can observe here. And other than that, you can see a certain amount of ligamental flamum or extra axial thickening happening in the posterior element, or it could be a venous flow void that again could be there. And you can see certain ischemic changes happening there along the spinal cord, which are apparent in the T2 hyperintense signal. So what is this problem that this 17-year-old boy is having? That should be the first question that we should have in mind. This diagnosis, when you get a similar picture of a boy complaining, of a youngster complaining of pain, weakness in both hands, wasting in both hands, and an MRI image like this, then the first thing that should come to your mind is Hirayama disease. Hirayama disease is a self-limiting disorder, and they usually have no sensory loss, and it is a LMN type of palsy. It is a severely disabling disease. But what is not true regarding the possible diagnosis among the given options? Option A, usually has no sensory loss. Yes, it has no sensory loss. It is self-limiting. Yes, it is self-limiting, usually limits within 1 to 2 years. I told you it is element type, so spasticity will not be seen. And it is a disabling disease. Yes, it is a disabling disease. So the answer after excluding all options is option C, which is spasticity is common. So Hirayama disease is a rare non-familiar monomelic amyotrophy originally described by Dr. Hirayama in 1959. Classical findings are going to be muscle atrophy and weakness of the forearms and hands, either unilateral or bilateral and without sensory loss. This usually progresses for 1 or 2 years before plateauing and eventually showing an abrupt arrest. Caused by chronic ischemic changes to the anterior horn cells or the cervical spine, secondary to a limited dural laxity, this is predominantly a lower motor neuron pattern of lesion. So that is very important. It is going to be element type of lesion. Hirayama postulated that increased intramedullary pressure during neck flexion causes stagnation of posterior epidural venous plexus, causing cord compression. So that is what had been shown there. It was a neck flexion that causes stagnation of posterior epidural venous plexus. So that is why you had that hyperintensity along the C5, C6 level. So that hyperintensity is because of the neck flexion. So the investigation of choice would be an MRI flexion image, and the characteristic diagnostic criteria for Hirayama disease is a distal limb muscle weakness and atrophy, onset between 10 to 20 years of age, unilateral or predominantly asymmetric pattern, insidious onset, gradual progression followed by an arrest, lack of pyramidal signs or sensory disturbance. This is very important. There are no pyramidal signs, meaning no spasticity and no sensory disturbance. And you have to exclude the other mimics that are usually happen in this age group, like a tumor or something else, or even an avian. MRI will show a crescent-shaped lesion in the posterior epidural space of the lower cervical cord or an atrophic spinal cord. Mild asymmetric cord flattening and increased signal intensity. It is only with specialized flexion MRIs that the diagnosis can be confirmatory. So you need to do flexion MRIs to make the diagnosis confirmatory. All of the pairs given below are false except option A, tuberous sclerosis, subependymal giant cell astrocytoma. Option B, neurofibromatosis 1, meningioma. Neurofibromatosis 2, astrocytoma. Von Hippel-Lindau disease, schwannoma. So tuberous sclerosis and SEGA are right. Neurofibromatosis 1, it is going to be astrocytomas or neurofibromas. Neurofibromatosis 2, it is going to be schwannoma. And von Hippel-Lindau, it is going to be hemangioblastoma. So the best answer is option A. Which of the following is not true regarding craniopharyngioma? It is WHO grade 1. Papillary variant is associated with BRAF mutations. Papillary variant is common in adults. Adenomatous variant is not associated with calcification. So the answer is option D. Adenomatous variant is associated with calcification. Craniopharyngiomas, you can divide them into two based on the histological subtypes as adamantinomatous and squamous types. Adamantinomatous has a bimodal age distribution, meaning it is seen in both adults and in pediatrics, whereas the papillary variant is exclusively seen in adults only. Papillary variant comprises 1/3 of all adult craniopharyngiomas. Histologically, these tumors tend to be more solid than cystic and can sometimes be localized within the third ventricle. These tumors do not, contrary to the adamantinomatous type, the papillary type do not form calcifications, and therefore they therefore often be distinguished using CT. Preferred site for DBS, for action tremors, is a very, very, very frequently repeated question. Is it ventro-intermediate nucleus of thalamus, ventro-anterior nucleus of thalamus, or option C, which is the globus pallidus, or option D, which is the substantia nigra? The answer is ventro-intermediate nucleus of thalamus. So this is very important. This has been repeated frequently. A 3-year-old child presents with a history of headache for about 1 year. Imaging shows lateral and third ventricular enlargement with periventricular lucency. What is the next step in management? The 3-year-old is presenting to you with headache, and there is going to be a lateral and third ventricular enlargement, meaning it is going to be because of an aqueductal stenosis. So what is the next step? Is it EVD without acetazolamide, EVD after 1 month of acetazolamide, or is it medical management, or is it B patient? The answer is B patient, straightforward B patient. Possible diagnosis. Option A, astrocytoma. Option B, hemangioblastoma. Option C, tuberculoma, or is it option D, metastasis? See, both astrocytoma and hemangioblastoma tend to present with a cystic lesion, which has a mural nodule. But I would like to go here with an astrocytoma, considering that it is a pediatric age group. You can see that it is a small skull. So I would like to go with astrocytoma. Pilocytic astrocytomas are more common in children and adults, whereas hemangioblastoma are more common in adults. If you see phlovoids on T2, then it gives a nice clue that you're looking at a hemangioblastoma. You need to see a phlovoid on T2 to call it as a hemangioblastoma. But that image that had been given to you was a CT. So still, since it was a small skull, I would like to go with pilocytic astrocytoma, which again presents like a mural nodule with a large cyst. Find the true statement about meningioma. All are WHO 1. Most common location is falcine meningioma. Grade 1 excision is not always possible. CP angle meningiomas behave as CP angle schwannoma. All are not WHO grade 1. You have WHO grade 1, 2, and 3. Most common location is falcine. Not true. Grade 1 excision is not always possible. Yes, grade 1 excision is not always possible. That is a true statement. CP angle meningiomas will not behave like CP angle schwannoma. Why? Because in CP angle schwannomas, 7th nerve palsy will be the late feature, whereas in CP angle meningioma, 7th nerve palsy would be the first presenting feature. Okay. Not true regarding oligodendroglioma. They are associated with 1P19, 1Q19P, and ATRX. Grade 2 and grade 3. Option B. Grade C, good prognosis. Option D, male predominance. So oligodendroglioma, not true statement would be option A, whereas all others are true. Oligodendroglioma itself will be grade 2. You have a WHO grade 3 oligodendroglioma, which is anaplastic oligodendroglioma. They're usually having a very good prognosis. There is significant male predominance. So the best answer would be it is 1P19Q co-deletion and ATRX negative. It is not positive for ATRX. Hence the answer would be option A. A 20-year-old male presents to you with complaints of back pain and numbness over the first web space. So which is the most common level of disc prolapse that is happening? So it is actually L5 nerve root which is getting involved, which is commonly affected in L4, L5 disc prolapse. So that is something which is a very classic repeat from the class, from the videos. A 35-year-old male presents with complaints of neck, of back pain and weakness in the right leg. On examination is found to have inability to dorsiflex the grade 2. What is the probable level of disc prolapse? Again, it is going to be L4, L5. Why? Because it is going to be the L5 nerve root. Image of craniotomy clips was given. What is it called as? So this is the image of the clip that had been given. So this is something which is called as the Rainy clips. It is called as the Rainy clips. So the answer is option C. MRI image of a brain cellular lesion, enhancing lesion with features of galactoria and amenorrhea were given. So, is it option A, prolactinoma, option C, craniopharyngioma, option C, acromegaly, or is it option D, Cushing's disease? The best answer would be prolactinoma. The best answer would be prolactinoma because galactoria amenorrhea classically goes to prolactinoma. Treatment for acromegaly, is it option A, surgery, option B, initial oculatory treatment followed by surgery, option C, medical treatment, option D, conservative management. The treatment for only one pituitary lesion is going to be a medical line of management, that is going to be prolactinoma, which is going to be treated with cabergoline and or bromocriptine. For every other lesion, it is going to be surgical, which is going to be the treatment of choice. A patient with head trauma and Jesus 8 is admitted in the ICU under your care. Which of the following is to be avoided? Is it option A, steroids, option B, mannitol, option C, enteral feeding, or is it option D, DVT pumps? See, mannitol may have to be given. Enteral feeding should be started early to prevent Cushing's ulcers. DVT pumps have to be given because these patients being restricted in movement, they have a tendency for venous stasis and going in for a DVT, deep venous thrombosis. So steroids are not to be given. So which of the following is to be avoided? The answer is steroids. Syndrome not associated with parietal lobe among the following. Is it option A, prosopagnosia, option B, Gressman syndrome, option C, Balint syndrome, option D, anosognosia? The answer is prosopagnosia because that is going to be a pathology associated with occipital lobe. A 10-month-old child presents with hydrocephalus and Chiari-2 malformation and myelomeningocele. What is the management? Is it option A, myelomeningocele repair followed by EVD for hydrocephalus? Option B, EVD first followed by myelomeningocele repair? Option C, posterior fossa decompression, or is it option D, conservative line of management? See, if you have a child with hydrocephalus, Chiari-2 malformation and myelomeningocele, the first step in management is going to be myelomeningocele repair followed by EVD for the hydrocephalus or a ventricular pretervation for a hydrocephalus. There is no point in addressing the hydrocephalus first because you have to close the exposed spinal cord first and then you have to go for a EVD. Which of the following is not a contraindication for lumbar puncture? Option A, brain tumor. Option B, brain AVM. Option C, pseudotumor cerebri. Or is it option D, brain abscess? See, lumbar puncture is contraindicated in brain tumor, in brain AVM, and in brain abscess because all these have a tendency to go in for a herniation, whereas it is not contraindicated in pseudotumor cerebri or the benign ICT or the idiopathic intracranial hypertension, where doing a lumbar puncture is and measuring the opening pressure will be the therapy will help you in treating the patient by assessing the need for a thecoperitoneal shunt. False regarding oligodendroglioma. Okay, I believe this is a repeat. Associated with 1p19q co-deletion and ATRX mutation, grade 2 or grade 3, associated with calcification and seizures are common. So, like we already discussed, it is going to be option A. Why? Because grade 2 and grade 3, yes, they are grade 2 and grade 3. They are associated with calcification and seizures are very common. But what is not true is, here it is 1p19q, which is being given rightly, but it is not ATRX. If it is going to have an ATRX mutation, it is going to be an astrocytoma. Not an extra-arachnoid tumor among the following. Is it option A, vestibular schwannoma, option B, meningioma, option C, pituitary adenoma, or is it option D, craniopharyngioma? See, extra-arachnoid means outside the arachnoid or arising from the arachnoid capsules. So not an extra-arachnoid. Whereas if you have vestibular schwannoma, it is going to be extra-arachnoid. Pituitary is going to be extra-arachnoid. Craniopharyngioma is going to be extra-arachnoid, but not meningiomas, because meningiomas will arise from the arachnoid capsules. It is not outside the arachnoid. True regarding neurosurgery. No Nobel Prize until now. First neurosurgery department was established in Ames, Delhi. Victor Horsley is the father of neurosurgery, the father of microneurosurgery. So there is no Nobel Prize until now. That is what is the true statement. A patient presented with meningitis, CSF taken and on India ink staining shows organisms are seen. What is the diagnosis? Is it option A, Cryptococcus, option B, Streptococcus, option C, Candida, or is it option D, Mycobacterium tuberculosis? If you have an India ink stain, then it is going to be a fungus, and the fungus here is Cryptococcus. So that will be the answer. Ventricular catheter tip is in the antrum of lateral ventricle. What is the point of insertion? So you know you have various points. It is Keen's point, Coccus, Dandy's, and Frazier. So if you see the ventricular tip in the atrium, in the antrum of the lateral ventricle, it is going to be the Keen's point. Moderate volume hemorrhage, surgical evacuation will be required in any size of hemorrhage, even if it is going to be very minimally large. If it is going to be in the cerebellar region or in the infratentorial region, then it will need a surgical evacuation. So that would be the last question. So this is the total number of questions that we had actually been able to collect from our students, and this will conclude our discussion on the INI SS Neurosurgery recall. So I believe the session was useful to you, and I believe this session was useful to you in bringing out in helping us discuss the various questions. So with that, I am ending this session. Thank you.